Okay, my name is Desmond McNeill, and I recently retired as Research Director at SUM, the Centre for Development and Environment, the University of Oslo. I was a member of the Lancet University Oslo Commission, and until recently I chaired the independent panel that followed after. So it's a great pleasure and an honour for me to introduce the first session. I'm particularly glad that Ole-Petter Ottersen, who was such an inspiring leader of the Commission, could be with us today. The report of the Commission, published in the Lancet February 2014, attracted very considerable attention, achieving a remarkably large number of citations in a very short time. It became, I think I can justifiably claim, a central point of reference for many of those who were concerned with the politics and inequities of public health. Although it was generally very well received, it was not without its critics. One of them is our second speaker today. Seeking to achieve change in a world of powerful and competing interests is no easy task. But I hope that this first session of our conference can reflect on the experience of the Commission and draw useful conclusions, especially with regard to the highly topical issue of universal health coverage. So I'd like to begin by introducing our first speaker. Ole-Petter Ottersen was from 2009 to 17 rector of the University of Oslo and is currently Professor of Medicine and President of the Karolinska Institutet in Stockholm. In 2002, he was appointed Director of the Centre for Molecular Biology and Neuroscience, a centre of excellence sponsored by the Research Council of Norway. From 2006 to 2009, he was Chief Editor of Neuroscience, the journal of the International Brain Research Organization. He's received several major awards for his research, including the Anders Jahre Medical Prize and the Lundbeck Nordic Research Prize. He has over 400 publications and is the editor of several books. And of course, he was also chair of the Lancet University of Oslo Commission. So, Ole-Petter, the word is yours.
Well, it's really great to be here. I feel like being at home. So thank you for the invitation, and I must say I'm really looking forward to what David McCoy is going to say as the second speaker. So that will be exciting, and I do hope that we will get a candid discussion about the Commission report and a candid discussion as to how we should proceed with these important issues that were raised in the Commission report and that are being raised in the SDGs. So as you know, these two issues are quite intimately connected. So, our chairman, already this doesn't work, I think. This one. Oh, doesn't work. Something is wrong. Now it's working. So I could use this one. Okay. This. Yeah, so Desmond already pointed to my background. So I trained 8 years as a president of the University of Oslo, to become president at Karolinska Institutet, where I am at the moment. But I should say, during my 8 years as president of the University of Oslo, this is what I really remember. This work that we did together to flesh out the conclusions in this Commission report. It was a fantastic endeavor, and I don't know whether it transformed the health service system, but it certainly transformed me as a person. And in fact, I took this report to Karolinska Institutet, and just a few weeks ago, we came up with the new vision for Karolinska Institutet. And perhaps you will recognize the message that is embedded in the second part of the vision. Strive towards better health for all. And all in this context, of course, means we should work across geographical borders, and we should work across generational borders, which means sustainability. And I should say there was absolutely no resistance in Karolinska Institutet when it came to this second leg of this vision. So, well, talking about impact, at least there is a tiny bit of impact, I should say, when it comes to the vision of our university now. And you should also take note of the fact that the timeline, the time perspective for our new strategy and mission at Karolinska Institutet is 2030. Does this remind you of another 2030-based report, Agenda 2030, of course? So what we are trying to do, and I think this is so important, is to ensure that the SDGs and the Agenda 2030 way of thinking is being instilled in all educational programs. I mean, education is key to really ascertain that the ambitions within the SDGs are realized eventually. Yes, so whenever I give lectures at Karolinska Institutet about global health, of course, I remind ourselves about the tremendous inequities that still persist. And I think this report is very much to the point. It's really scary that we have this injustice in health worldwide. 5 billion people, no access to safe, affordable surgical and anesthesia care when needed. And also what I'm trying to do and what I'm trying to instill in my own university is this understanding of what is global health. And of course I fancy this kind of definition where equity is built squarely within the definition of global health. So back to the commission. We had commissioners from all over the world, and I'm happy to say that many of them are present in the audience today. We have Satiko here, we have Sigrun, and Yashodhara not least. The meeting in India was transformative. It really paved the way for the major conclusions of our commission. So thank you for hosting us. It was really an amazing, but also in many ways, a sort of depressive journey into the health problems in India. We have Desmond here, of course, and unfortunately, we lack some of the commissioners here, but many are here, and it's great to see you all here again. I hope I didn't forget anybody here. And Inger, of course, is here. Cecil is here. Many representatives of SUM are here today. So this is, of course, what it's all about. What is health? The idea of a university is really, and you could go back to the etymology of the word university, is to understand the wholeness of things, the complexity of things, the entirety. And this is, in fact, one of the most important perspectives, I think, for our commission report, that health is not just about cells, molecules, organs, but it's also about politics. And it's a very simple idea, but I must say that there is still quite a lot of resistance to look at health in this rather, let's say, complex and holistic manner. But we have to go in that direction. There is no other option. And I think that the political determinants that should be embedded in all curricula for medical students and health professionals. In our commission, we ended up with 5 different sort of dysfunctions that we believe still today are, let's say, hampering progress in global health and global health equity. And I should draw your attention to the first one, inadequate policy space, because of all the different dysfunctions that we came up with, I think that time has told us that inadequate policy space is perhaps one of the most important challenges of our time. I mean, we must be reminded about what a state is all about. I mean, it has monopoly in violence. That's one thing, police, army, and so forth. But another and key responsibility for any state is to protect the health of its population. And what we see today is that this second task of any state that really defines what the state is all about, the second objective is not really easy to carry out. And in fact, 2 days ago, here in Oslo, we had a fantastic meeting, Northern Future Forum, and I moderated a debate between these people here. Perhaps you recognize some of them. Theresa May, Erna Solberg, and so forth, 8 different prime ministers. And what was the topic? It was health, equity and health. No one should be left behind, you recognize that. But I'll tell you, and it's a secret. What happened in this discussion was that, for instance, we had a discussion on obesity, diabetes, and almost all comments related to the choice of the individual. The choice of the individual. We choose an unhealthy lifestyle. And of course, I was modest, but I said, perhaps there is something above the choice of the individual. Perhaps there is a sort of sphere, political sphere, that we have to look into. Is it really so that states can protect the health of its population? Or is it so that we have to look into the politics? And this is also exactly the thing that happened when I met with Michelle Bachelet in Santiago, just after the commission came out. She's a pediatrician, you know. Now she's the High Commissioner for Human Rights in the UN. And this is one of the most, I wouldn't say just only interesting discussions that I've had after the commission report came out, but also one of the most emotive. Because what Michelle Bachelet said very clearly is exactly this, that the grandiose, the big, the ambitious plans that they had to protect the health of the Chilean population, for instance, by putting a traffic light system and labels on unhealthy food, they couldn't really succeed because of the trade agreements that interfered with the political ambitions. And I think this really proves the point that one of the most important challenges is exactly this, how to protect the state's policy space for health. Health is impacted by power disparities, certainly, and health is subordinated to economic goals. Two very, very important conclusions of our commission. And by the way, when it comes to economic goals, I must say this summer I was a bit depressed when I saw this, because this is really the epitome. It epitomizes what we're talking about when health is subordinated to economic goals. This summer I understood that the US government retracted its support of breastfeeding programs. Perhaps things have changed after this, but at least this came up as a piece of news this summer. And this, I think, is a stellar example, excuse me for using the adjective stellar, don't misunderstand, but it's a stellar example of how health can be subordinated to economic goals. We have a lot of things to do. Well, one thing which I think is a bit sad is that among us today we don't have Ilona Kickbusch. She was invited. But Ilona Kickbusch also was instrumental. She was not part of the commission, but her thoughts and her initiatives were very important for the follow-up of the commission. And now we have a lot of think tanks, of course, all over the world discussing these issues that are on the table for us today. And I think Ilona was one of the first ones who really started to use think tanks creatively into the follow-up of the thoughts in the commission. How can we measure impact? Is it really so that this commission has had any impact at all? I'm sure David will come up with some thoughts when it comes to exactly this. But, and of course we should be modest. We should be really modest. It's for nobody to tell whether it really has had an impact. But I think, now it stops again. My goodness. Something is wrong here. Okay, I'll just this one. One of the recommendations in our report was to establish an independent panel of global governance for health, and Desmond and many others here, they have played an important role in this particular follow-up. And when it comes to the impact, I think you could go to the homepage of our commission, because there you find all the different publications that have come up following the commission report. Many of those relate to trade agreements and the restriction of policy space, obviously, and I think this will be an issue that will come up for discussion. Some deal with extractive industries and health, very important issue. Law and human rights, and this is more or less a compilation of many of the papers that have followed after the commission report was published in 2014. So in one sense, one can say at least that the commission has had an impact through the follow-up work in the independent panel. It has had impact on institutions, as I said, including my own. It has had an impact on national strategies. We are discussing now in Sweden how to come up with a new strategy for global health and implementation of the SDGs. And I dare say the political determinants figure prominently in the discussion now in Sweden. Impact on evidence base, almost at the same time, I think, as the Commission report was published. This book came out from our colleagues here in Norway, and some of them are present here today. I think it's fair to say that this turned out to be a very important resource to really push forward an adequate health policy in many countries. And now, going back to Sweden, a very important discussion comes up now. And we have Johan Dahlstrand here, who is one of the key persons in this particular endeavor. And the endeavor is to establish a new commission that doesn't look at what impacts health, but how health impact other issues, among them peace. How can health and equity in health impact peace? Johan Dahlstrand is here and can answer questions if they come up. And then we should be reminded about what happened in Oslo. I can vaguely remember, I was just a kid at the time, when in fact the issue of this new commission was put to the fore in the university aula here in Oslo when Martin Luther King Jr. got the Peace Prize. And just after this happened, he gave a speech and he said, of all the forms of inequality, injustice in health is the most shocking and inhuman. So this, I think, is the platform for the new commission in Sweden. This should have appeared prior to our commission. This is a paper that is beautiful because it analyzes commission reports and it asks how could we tell what are the success factors. And point 10 is perhaps the most important thing, and that is that we should extend the lifespan of a commission through discussions like this, through symposia like this, through all the work that has been done, for example, through the independent panel. So I think at least point 10 is taken care of as we speak. The final issue, I really enjoyed the talk, the keynote of Jomo Sundaram. The cost efficiency of treatments and medicines are key to a just and equitable healthcare system. Just a couple of weeks ago, I was in Kyoto at a fantastic meeting, SDS meeting it's called, Science Technology meeting. The Japanese Prime Minister opened the meeting. And tribute was paid to the two Nobel laureates. They are selected from Karolinska Institutet, as you know. And this year, Allison and Honshu were selected for their remarkable discoveries on checkpoint inhibitors, new ways to treat aggressive cancers. Fantastic. But what happened when they came back to Stockholm? Svenska Dagbladet, one of the newspapers in Sweden, said that because of these medicines, Sahlgrenska sjukhus is more or less bankrupt. These medicines cannot be implemented even in one of the richest countries in the world. Can you imagine? So what should we do? I've taken an initiative now to see whether we could harness the innovative power of the universities, not only to come up with new medicines, but to come up with new medicines and treatments that can be implemented. It's not a bad thing to be able to implement new medicines and treatments. So I think the solution is a center of sustainable medicine. And finally, I believe in the persuasiveness of facts. Thank you for your attention.
Thank you very much, Ole Petter. Our next speaker is David McCoy. He's Professor of Global Public Health at Queen Mary University, London. From 2012 to 17, he was Director of MedAct, a public health charity that works on the underlying social, political and ecological determinants of global health. After qualifying as a medical doctor, he spent 6 years as a clinician in the UK and South Africa. He spent a further 7 years with the University of Cape Town and the Health System Trust, an NGO established to support the post-apartheid transformation the South African healthcare system. Since returning to UK, he's worked across the NGO sector, academia and the National Health Service. He's a member of the Steering Council of the People's Health Movement and a trustee of the Centre for Health in the Public Interest. The title of his presentation is Confronting Anti-Politics in Global Health. David, the floor is yours. There he is.
Good morning, everyone, and thank you so much for the invitation to be able to speak at this wonderful conference with so many wonderful people in this room. I think it's great to have a conference that addresses politics head-on, the politics of health head-on, and I'm going to be quite political about the topic. You know, let's be political about the politics of health. I'm not a political scientist. But as Desmond mentioned, I spent about 10 years in South Africa between the years of 1992 and 2002, and there could not have been a better opportunity for a young doctor to learn about the politics of health. I worked in many of the rural parts of South Africa, and it was obvious to me that the social and economic disparities, the structural violence of apartheid, and its impacts blighting the lives of millions of people, both physically and psychologically. So it perfectly illustrated Virchow's dictum about politics being nothing more than medicine at a larger scale, and that medicine really does need to enter into the larger political and social life should it fulfill its great ends. I worked as a pediatrician for a number of years. Worked in a hospital where I had to sign the death certificate of children on a daily basis. And this UNICEF conceptual framework helped me to understand just how important the political and ideological superstructure is to determining who lives and who dies. And South Africa was also a perfect microcosm of our globalized world in many ways. It had the legacy of colonization that many parts of the world have. It experienced an imposition of neoliberal policies from the outside. Very soon after the ANC came in, it quickly realized what it could and couldn't do, courtesy of the World Bank and the IMF and many other powerful actors that Jomo talked about. It demonstrates, for example, the existence of a damaging food system. It produces the double burden of both undernutrition and obesity in spite of having a highly productive agricultural sector. So, you know, when I was in South Africa, I learnt and understood how globalization was impacting on health. And when the Commission on the Social Determinants of Health came out, I was both pleased, but I immediately recognized some of the kind of core conclusions of that commission. That the unequal distribution of global health is not in any way a natural phenomenon, but the result of a toxic combination of poor social policies and programs, unfair economic arrangements, and bad politics. And importantly, the commission talked about the need to change the distribution of power. Very important conclusion. It's not about policy, this is about power. So when the Lancet Oslo Commission was established, I was intrigued and hopeful. Would it build on these recommendations from the Commission? Would it build on these conclusions? Or were we just going to get old wine in new bottles? Was it going to say anything new? After all, this Commission had been established after the 2008 financial crisis. It had been established after the publication of Richard Wilkinson and Kate Pickett's Spirit Level, which I thought did a brilliant job in explaining the psychosocial pathways by which social inequality produces poor health, and also the societal effects of inequality, the weakening of social capital, the loss of trust, the propensity for increasing violence, the erosion of democracy. All of these are produced as a result of widening social inequalities and in turn produce poorer health. the Lancet Oslo Commission also followed the regular publication of Oxfam's wealth inequality reports, which produce these kinds of shocking facts on an annual basis. But as has been already alluded to, I ended up feeling a bit perplexed and a little bit disappointed with the report. My assessment was that the Commission should be given an A for its intent and ambition. I thought it had some good analysis, but there were some faults, to which I will come to later. But it was pretty poor on the recommendations, which really amounted to organizing another multi-stakeholder talk shop and doing more research. There was nothing political about the recommendations. And if anything, I felt that the report ended up being anti-political. However, the more I thought about it, the more I thought, wow, this is a great opportunity to force a discussion on how we as a global health community not only understand the politics of health, but also understand our own politics, the politics of global health. And so I began a discussion with a number of commissioners. Some of them are in this room. And I wanted to know, how did you arrive at these recommendations? All this political analysis, and then no political recommendations. So I wrote a blog, first asking the Commission to withdraw its recommendations and come up with some better ones. But really what I wanted to do was to raise questions about why there was a disconnect between the political analysis and the unpolitical recommendations. Now, for some of you who were part of the Commission, please forgive me, because I want to raise these questions again. And I do so because I think these questions continue to be important, and if anything, they are more important today than they were in 2014, given the many bad things that have happened since then. So in my blog, I hypothesized 3 explanations for this disconnect between the analysis and the recommendations. The first hypothesis was that the Commission actually thought that these were good recommendations, that this was merely a case of being tactically pragmatic. And in fact, in the words of one commissioner, the recommendations were designed for an audience who still need convincing and persuasion about the analysis. Another commissioner noted, we simply did not see how unequal power would go away from global governance in the near future, hence we came up with modest recommendations, and we admit that they are insufficient. The second hypothesis was that the recommendations, in fact, represented the lowest common denominator. The Commission had to find recommendations that everyone could agree to. And in fact, I was informed that there was some disagreement about the recommendations, and I was told that one commissioner had insisted on words like capitalism and colonialism being removed from an earlier draft, and had pushed for recommendations that would meet the approval of a wide range of multi-stakeholder actors. This in turn prompted me to write a second blog. Now, both of these blogs, by the way, are in the public domain, and they are in the public domain along with the responses from a number of commissioners, for which I was really appreciated, because I really wanted to foster a dialogue about this. It wasn't about just being critical. And I'm, of course, hugely, hugely grateful to Ole Peter and others having the generosity to allow me to continue this dialogue and this debate. I'm certainly not trying to pick a fight with anyone, but I do feel we need to be frank and open if we're going to talk about the politics of health. And that means being a little bit uncomfortable sometimes. My third hypothesis was that maybe there was some self-censorship going on. Now, I'm no expert on the psychology of self-censorship, but I've read enough Noam Chomsky, I've read a bit of Antonio Gramsci to know that for the most part self-censorship occurs unknowingly, perhaps even unwittingly, I've also studied how the same power in politics that shapes the global political economy operates across the global health landscape. And I know from my own personal experience just how easy it is to avoid speaking truth to power, how easy it is to avoid swimming against the mainstream, how tempting it is to avoid being labeled as being political or being radical, being labeled as a troublemaker, or worst of all, being labeled as an idealist. So I think there's always a tightrope to walk. You know, we all perhaps want to make the obvious point that politics and unfettered capitalism is currently destroying the planet and crushing the hopes and lives of millions of people. But we fear doing so. And in the case of the Lancet University Oslo Commission, the reason why I gave it only a B for its analysis is because at times it muddied its own analysis, but I think trying to please everyone. So, for example, in the Commission, it talked about privatization, deregulation, and trade liberalization having helped generate ever greater flows of goods, people, money, information, ideas, and values, producing an unprecedented growth that has increased material prosperity for hundreds of millions of people, greatly improved their health and well-being. It talked positively about foreign direct investment, and it talked about transnational corporations yielding all kinds of enormous benefits. And yet I don't know of any evidence that justifies the claims being made here about the holy trinity of neoliberal, the holy neoliberal trinity of privatization, deregulation, and trade liberalization. Nor do I know of any evidence that transnational corporations perform well in terms of job creation, raising incomes, or driving technological advance. In the pharmaceutical sector, for example, it's done the exact opposite. Similarly, the Commission's discussion of the 2008 financial crisis was indicative. It talked about how should governments respond to the financial crisis? Should they institute counter-cyclical spending? Were there better ways of implementing austerity that weren't going to be quite so harmful? But not much about how we change the system of global finance. Nothing about the need to consider much of the debt that has been passed on to governments and ordinary people as being illegitimate debt. Other aspects of global governance that were excluded from critical analysis included the role of foreign aid and private philanthropy, which I think help to sustain democratic deficits and disparities in power, and they help shield unfair trade and investment agreements from being acted upon. So Jana Scholter, who comes from the field of development studies, has written extensively about globalization, places actors into three broad groups. Conformists, who uphold and reinforce prevailing structures, systems, and norms. Reformists, who try and minimize the harm and correct the flaws while leaving the underlying structures intact. And transformists, those who want to actually change the social and political order. And similarly, Matthew Spark, who's written about global health governance, describes three types of civil society organizations. Market fundamentalists, who act as agents of neoliberalism, those that mitigate the deficiencies and harms of neoliberalism, but again keep the underlying social and political structures intact, and those who seek to oppose and resist the underlying arrangements. So I suppose if we want to discuss the politics of health as a global health community, I guess we need to think about where we sit on this kind of political spectrum. So what I did was to suggest that we actually have a commission on power, politics, and alternatives. Firstly, to deepen and broaden our analysis of politics and power. I talked about three things that we could do. Describe how power is structured and organized and how it's used to undermine democracy, equity, and public health. Critically analyze the role of aid and private philanthropy. and examine the influence of the US corporate military government complex. I think if we did this, we would really get to the heart of the political origins of global health inequity. For now, I just want to briefly gloss over the first and third recommendation and focus on the second, because I think this has direct relevance to us in the health sector. And I want to throw out another hypothesis. Do our current global health governance arrangements help block transformative change by reinforcing existing power disparities through the means of charity and philanthrocapitalism and through the practice of anti-politics? I'm running out of time. I'd briefly talk about anti-politics and refer to the work of Schedler, who again comes from the field of development studies, who describes 4 types of anti-politics. Instrumental anti-politics, whereby political decisions are made by technocratic experts, often based on cost-benefit analysis, and projected as being entirely rational and neutral, no politics. There's amoral anti-politics, by which the public domain is privatized, and people are reduced to being rational, utility-maximizing economic human beings, whose interests and preferences are simply expressed through the market. No need for politics. There's the moral anti-politics, which acts by reifying certain normative positions and stifling democratic or political debate through the labeling of any contrarian positions as being immoral or unethical. Don't talk to me about politics. We have lives to save. Don't talk to me about democracy or institution building. There are people dying today. There's the aesthetic anti-politics, where we trivialize issues through images and homilies. Think about Coca-Cola and its corporate social responsibility programs. Think about Angelina Jolie in Africa. I made 2 other quick recommendations, quickly. One was the need to produce an alternative development paradigm. And the third, which I want to end with now, is about how we build on the point made by the Commission about needing to support social movements, to challenge undemocratic processes, and to protest against unfair policies. One commissioner called for a revolution and for strong movements around the world to show their anger and to call for change. And this again echoes the point made by the Commission on the Social Determinants of Health that talked about the emancipation of women, the abolition of slavery, and the fundamental importance of social movements to effecting change. So my question to conclude is really to ask a question about what we do as global health experts, as global health academics, people who participate in commissions, who publish in high-impact journals. What do we do to support social movements? Should we just limit our role to being technocratic experts who influence in the corridors of power, or do we need to engage with those who are resisting political oppression and exploitation and injustice? Scholter, in making some concluding remarks about how we reverse some of the harms of neoliberal globalization, talked about combining ambitious reformism with cautious transformism. Perhaps that's what we need to think about doing, but no place here for the conformists. It's just the reformists and the transformists. So I guess part of what I'm saying is that there's a lot of bad politics happening in the world. But I do still believe and think that the global health community has an opportunity to be part of the good politics. And we need that more now than we've ever needed it before. So thank you very much for listening.
Thank you, David. Yes, our third speaker is Judit Rius. She's an attorney and policy expert, currently working as senior consultant with the Bureau of Policy and Program Support for UNDP in New York. She was for 7 years the US manager and legal advisor for the Access Campaign for Médecins Sans Frontières, and has also worked as Knowledge Ecology International in Washington, D.C., providing technical assistance to countries in negotiations at the WHO and the World Intellectual Property Organization. She's worked in the legal departments of a pharmaceutical company and software and IT companies, and she also teaches graduate programs on trade and global health at the New School, New York. The title of her presentation, Challenges and Opportunities to Reduce Health Inequities, a Practitioner Perspective. Judith, the word's yours.
Hi, good morning. I have to set up my computer, 2 seconds. It's a little bit narrow. Thank you, sorry about that. Thank you. Thank you. So good morning, everybody. First of all, thank you so much to Antoine and the team for a very well organized conference, and thank you to Professor Sakiko Fukudapa, who has been a mentor and an inspiration for many years. Oh, thank you. Yes, I do need to grow, and I'm going to grow right now, especially after the presentation. That came from. Thank you, Professor Fukuda Sakiba, that I'm not only sharing the same length, so I've been learning from you from years, so it's an honor to be invited and to follow your steps, hopefully one day. So this is a conference about politics, so a disclaimer. I do not represent the views of my current employee, my past employee, or maybe any future employee I might have. Because of course, if it's about politics and we need to speak the truth and we need to say what we think about politics, we should, in current world and employment opportunities, we should be very careful about what we said. And I'm not going to be careful about what I say. I'm going to try to share my perspective about what I see and what I think. Some things are right, some things are wrong. This is a very personal presentation. So that's why the disclaimers are needed. I have to say I've been given 10-15 minutes to analyze the report and also to say how is it relevant today in 2018 by somebody who works mostly on a very niche issue, is the issues of access to medicines and innovation to health technologies. I was very thankful that one of the case studies of the report talk about the issues of knowledge generation, knowledge dissemination, intellectual property, and specifically the issues of access to medicines. I very much agree with the analysis of the report, and I thought the recommendations were pretty good, but I think what was more important is that the issue was included in the report because it's one of the biggest causes of health inequality in the world. How scientific knowledge is generated, distributed, and who has access to it or who doesn't. So just by focusing on the issue as one of the 7 case studies, I think the report nailed it, and just by recognizing that everything in access to medicines and technological production of scientific knowledge is political, it's a good approach. It's everything is political on access to medicines and innovation, and everything, why people have access or not have access to health technologies, why people suffering from Ebola have or not have, in this case, any health technology to save their lives is clearly rooted in one of the major inequalities of our century. So thank you for covering the issue in the report, and thank you for allowing me to talk about what has happened in the world since the report was released in 2014. So I think the report had many good conclusions. As I mentioned, everything in my field is outside of the scope of ministers of health. and health actors. So from priority setting about what health technologies, medicines, vaccines, and diagnostics are going to be produced, innovated, and which ones will not, how they are funded, how they are incentivized, how they are distributed, and the last mile, who gets access, at what price, and at which conditions. Nearly every step of the way on the health technologies field is outside of the realm of health actors. So yeah, the importance of trade, of course, the importance of all the actors outside of health is extremely significant and important in the field of access to medicines. Maybe let me illustrate the story of why access to medicines and health is so political and why it's so unequal. Let me illustrate a story by a positive story and why the recommendations and the analysis of the reports is still valid now. And the story is the story of the TPP, the Trans-Pacific Partnership Agreement. I don't know how many of you, I'm sure many of you, have heard about the TPP. So the TPP is now called the Comprehensive and Progressive Trade Agreement. How do we move from a Trans-Pacific Partnership Agreement to a Comprehensive and Progressive Trade Agreement? So it's a long story, a story that many in this room follow with me for 6 years around the world, following the trade negotiations. It was a really interesting experience, but it was also very painful. I think the civil society activists that followed that process and tried to influence that process learn a lot about politics. So it's overall a success story in the field of intellectual property and access to medicines, because the first draft that was leaked, it was a secret negotiation. The TPP was a secret negotiation that at the end stage involved 12 countries. It was supposed to be the biggest trade agreement in history of trade. It was supposed to cover around 40% of the world GDP. And the first draft was leaked several years ago of the intellectual property chapter was, and I'm an intellectual property lawyer, it was analyzed by me and by others in this room, and our conclusion was the worst intellectual property chapter we ever seen in a trade negotiations. The protection of monopolies went to a level that we've not seen ever in a trade agreement before. So patent evergreen, I can bother you with the technicity, but I think we have a whole presentation where we're gonna look at the text. But basically it was an expansion of monopoly power to restrict competition in the innovation, manufacturing, and distribution of pharmaceutical technologies that will raise the price of medicines, but will also inhibit much needed technological innovation. So 5 years later, we dedicated the first 2 years of the movement, it was a civil society and academic movement, to generate data and evidence. So I don't disagree that data and evidence is important, and to educate about the impact of these provisions on public health. That was difficult and challenging, but it was achieved, I think. Once the agreement was going to be signed, there were important modifications made in the agreement that reduced some of the worst provisions. But the agreement in itself was not a good agreement. It contained provisions that we knew, and everybody in the room and everybody negotiating knew we would have had a negative impact on access to medicines. Patent term extensions, secondary patenting for products that were on the market, slightly modifications of medicines will be granted new 20-year patent monopolies. Biologics was a huge issue on the TPP. Additional regulatory protections against competition for new cancer treatments and vaccines. So we knew the text was not going to be good. The text was signed in 2016, and it was a TPP at the moment. It was 12 countries signing an agreement against every data and evidence on the earth that we could generate and many others could generate. It was a political decision. It was a trade-off. And everybody knew that was a political decision. Why do I say it's a positive story? Because one of the governments, of the 12 governments, the United States, publicly withdrew from the trade agreement. And the agreement fundamentally changed. The agreement changed in name. It's now TPP 11. The countries decided to call it progressive and transformative. And some of the worst provisions on the intellectual property chapter was suspended from applicability. So it was clearly a win from the intellectual property chapter provision, but it was a political win. It was nothing to do with data on evidence. It was a decision that the tax of higher prices that countries were going to pay for years to come, and patients around the world were going to pay for years to come, was not worthy anymore if the TPP was 11 countries instead of 12. So the power of the withdrawal of one country, potentially huge political and human rights and public health significance for millions of people to come. That doesn't mean that these provisions are not in other trade agreements, that we're not seeing a proliferation of more TRIPS plus provisions in our trade agreements, but I think we need to learn from that success on the TPP and now the CPT. The power of civil society engagement, working closely with academics. The years of data and evidence generation is important, but it's insufficient unless there's a huge political movement linked to it. And the engagement of ministers of health and health authorities in the negotiations. Nearly all governments that negotiated the TPP did something that previous governments have and previous negotiations have not done. They brought ministers of health into the trade negotiations, sometimes patients into the trade negotiations. I followed trade for many years. I never seen a minister of health in a trade negotiation and patients speaking to trade negotiations. So that, I think that's important, and we should be complementing and multiplying that. Most of the best negotiators and the most robust opposition to the monopolization of scientific knowledge and access to medicines came from countries within the OECD. So the TPP contained 12 countries at the beginning, and most of the stronger opposition was from Australia, New Zealand, Canada, Malaysia, Chile. These are some variety of incomes, and they were the countries, traditionally trade agreements, TRIPS plus, have been opposed by developing countries. In the TPP, there was a unified front of developed and developing countries opposing these TRIPS plus provision. For me, that's a very big lesson and a big change of political dynamics. And then the final end of the big lesson is that everything is political. Oh, I have 3 minutes. So what has happened since 2014? So the TPP, here you have it. It's concluded. It's in process of being ratified. It's now called the CPPT, and the TRIPS plus provisions are suspended. So that's a positive news. But most of the rest is not so positive. I mean, we still see high levels of mortality and morbidity that could be avoided in the world because medicines exist and health technologies exist, but they're just not available and affordable in the world. The report mostly focuses on the lack of access to medicines in developing countries. These slides try to show you that one of the most significant changes since 2014 has been the globalization of the crisis of high prices of medicines around the world. I am from Europe, I'm from Spain. The issues of lack of access to medicines for hepatitis, cancer, and many biologics is now a global concern for governments and civil society around the world. So I think any future work on this issue has to be more global and has to recognize that these are global challenges and needs, and there are patients around the world that are not having access to medicines. The globalization in terms of moving away to not only look at medicines, but also looking at diagnostics and vaccines and medical devices. The challenges of the current way of financing and innovating is across health sectors and across health technologies and across diseases. So we are having huge problems on lack of access to new vaccines, like pneumonia vaccine, one of the biggest killers of children under 5, is completely unaffordable for many countries around the world. Cervical cancer vaccine, HPV vaccine, hugely important prevention tools that are completely out of reach for millions of people and countries around the world. The other big component of shift in the field of access to medicines and innovation that has happened since the report was released is the globalization of the market failure. So in 2014 and for years, we have known that the current system doesn't promote innovation for neglected patients. We knew about Ebola. I mean, Ebola was discovered in 1976, and we still do not have an effective and appropriate vaccine or treatment or diagnostic. We know about Chagas, we know about tuberculosis, we know that neglected patients and neglected diseases are a market failure of the current system. But since 2014 and more, increasingly more, we're recognizing that the current innovation system doesn't work for anybody, not even people living in Europe or in the United States. And the challenges with antimicrobial resistance are hopefully an important wake-up call for that. we see a gap, a lack of discovery of new antibiotics over the last, since the 90s, 1990. And what happened in the 1990s? The globalization of through trade agreements of a form of funding innovation. So the TRIPS agreement, just a reminder, was signed and ratified in 1995. We have not seen major discoveries on innovation on antibiotics since the 90s. So it's an important evidence, piece of evidence of what is wrong in the current system and what is working and what is not working to promote innovation. Since 2014, we have also seen a shift in geopolitics of access to medicines. So I will say, and I'm in Oslo, so I need to talk about the Global Health and Foreign Policy Resolution and the Oslo Group. There's been important developments. I'm based in New York, and I follow politics of health. Most of the discussions on these issues for the last 20 years have been in Geneva, in the corridors of power of Geneva. And we see a shift now, some of these discussions moving to New York, to the UN General Assembly. Of course, this year, there's been just this year, 2 high-level meetings on health-related issues, highly relevant to the lack of access and innovation to health technologies, one on tuberculosis and the other one on non-communicable diseases. We have seen the Global Health and Foreign Policy Resolution of 2016 contain important language on the lack of policy coherence and the lack of policy tools for access to medicines and innovation by governments. So there is important language that's being discussed in New York. It's just language, but it's important language and important conversations. And then we have the UN High-Level Panel on Access to Medicines that was established in 2015 by the former Secretary General Ban Ki-moon, who had a group of 15 high-level panelists and experts, including Professor Sakiko Fukuda-Par, that just a few months after the adoption of the SDGs, ask, I think, a critical question, the lack of policy coherence, the fact that there is policy incoherence between health, human right to health, public health priorities, human rights law, as well as trade and investment agreements. That report was released in 2016, and it contains a variety of recommendations that I think are important for these commissions to consider, including recommendations on new models for innovation, alternative system for financing and incentivizing innovation, the generation of data, transparency recommendations, as well as recommendations that we have known for a long time. I mean, there's nothing majorly new, except that it's elevated politically. This is now, hopefully, a political priority, or should be a political priority, outside of just the domain of ministers of health and corridors of power in Geneva. The report recommendations have been received with a variety of different perspectives, but some of the recommendations, including on the issues of recognition of the current, the failures of the current innovation system and the need for alternative, have started to move. I think in the field of antimicrobial resistance and tuberculosis, the fact that we don't have innovation for several years and the fact that we are running out of options for treating life-threatening diseases is potentially a very promising and wake-up call. So the 2016 UN Political Declaration on Antimicrobial Resistance contained very interesting and promising language on the need for alternative on the way we finance and we generate scientific knowledge for antimicrobial resistance, very aligned to the recommendations of the UN Secretary General High-Level Panel in the need for new incentives for innovation that do not rely on the monopolization of scientific knowledge. But again, these are just very nice statements, very good political declarations. The key now is going to be, do we have the political will and the political space to implement them when we are incentivizing, mostly at this moment, publicly funded incentives for research and development for antibiotics? I am being told that I'm running out of time. I think something I learned as a practitioner in the field of access to medicines maybe is of the power of private sector contributions to creating interference in policymaking. I think you have to talk about power, and we need to talk about politics. We need to talk about who is funding the representatives, the government representatives that take decisions. I'm just giving you a snapshot of the US government because that's where I live, but this is not a US government problem. This is a global problem. So I think it's important to look at contributions, financial contributions of private sector interference in policy space that governments should have to take the decisions that are better for all of us. It's not only governments. I just want to show you another slide from the same source, the Kaiser's New Foundations, on funding for civil society and patient groups in this field. I want to show you that there has been a clear rise on funding for NGOs and civil society and patient groups working on access to medicines by private sector. Just the UN negotiations in New York on TB and non-communicable diseases. Most of the NGOs and civil society that were present in that meeting were funded by private sector or by philanthropies. There's very little independent civil society left working in this field, especially NGOs working in developing countries are having a very hard time to maintain their expertise, their staff, and their capacity to influence like they did in the TPP, because funding sources are being withdrawn with a very clear political intention. So I think it's important that we look at how to maintain civil society engagement in this field in an independent, evidence and public health driven way. And finally, just a quote from the Commission that really inspires me is, I was reading about the Commission's report and I was reading about the thinking on the generation of the report. I think the commissioners really had, from outside, I was not in the meeting, but had this feeling that there were unacceptable, fundamentally unacceptable facts that they were being confronted when they were preparing this report. And they were difficult and unacceptable truths that need to be addressed. For me, the most unacceptable truth that needs to be accepted and that we need to accept and we need to deal with is that people are dying. Alec in the United States because of lack of insulin. Tobeka in South Africa because of lack of access to cancer treatment. I met Tobeka, I know these people, these are human beings that are unnecessarily dying because of lack of access to medicines that are available to, or used to be available to many of us. There is fundamental politics of inequalities are impacting human beings, and I think their faces, their testimonies, and their lives is what should inspire us to be more political and to be more impactful in our work, and to look at how, through my field and access to medicines, the need for change is not only overdue, but it's an imperative on our condition of human rights. Thank you.
Thank you very much. So we have our final speaker, Rosalind McKenna. She's Program Officer with the Access and Accountability Division of the Open Society Foundation Public Health Program based in New York, where she's focusing her work on governance for health and access to medicines and innovation. Prior to joining PHP in 2014, she was coordinator of Amnesty International Ireland's program on economic, social and cultural rights. She's previously worked for a UK Member of Parliament and the Scottish Court Service, coordinating Amnesty International Ireland's programme of work on human rights-based approaches. Her work has focused on legal enforcement and monitoring of economic, social and cultural rights, in particular the right to health. The title of her presentation is Global Governance for Health, a Philanthropic Perspective. The floor is yours.
I'm mainly trying to grapple with the health equity issue or height equity issue of where I should stand on this podium. Thank you to everyone that's here, and thank you to the organisers for inviting me to be part of the panel. And I'm really struck with not just responding to David's presentation, so I will try to stick to what I was planning to say originally. But I'm really struck at the remarks that Desmond made at the start about the influence that the Lancet Oslo Commission had and how different stakeholders have taken up that agenda or responded to that agenda or not responded to that agenda. So just to give some reflections from Open Society Foundations. But maybe to start, I want to go 15,000 kilometres south of here to UCT in South Africa. And last year when we were in South Africa for a meeting around national health insurance, And as always, my reflections on that policy-making process are very heavily informed by the Ask the Taxi Driver research methodology. On the taxi to UCT, asking this taxi driver about what he knew about national health insurance and the policy reforms that had been touted for a long time. And he could speak very eloquently about the public health crisis and the challenges he faced with his family in accessing care. But this NHI was just something that, you know, he sometimes read about in the Daily Maverick, but didn't really see anything else in terms of his voice in a policy space. And then getting to UCT to meet with some People's Health Movement team members and wandering around these myriad corridors. I don't know if you've been to UCT, but it's this very old traditional school of medicine. And coming upon this plaque that was mounted on the wall that said, "In a democracy, the ultimate responsibility for decisions on health policy lies with the public, but at present, that's not what happens." So how does that sense of public ownership of health policy making and the Lancet Oslo Commission relate to Open Society foundations? So Open Society is more known for its work around democratic governance, protection of human rights, participatory democratic processes. But since its founding more than 20 years ago, public health work has always been a big part of the foundation's work, either working on reform of health services following the collapse of the Soviet Union in Eastern Europe and Central Asia, but also over the past 20 years looking at discrimination that people encounter in accessing health services linked to their identity or basic failures around access to care for marginalised groups. I joined OSF 4 years ago, and at that time we were working a lot on accountability and a lot on financing within the health sector. But there was a real recognition that our work was not sufficiently political. It didn't speak to power. And very much informed by the Lancet Oslo Commission, in 2015 we developed a new strategy of work around governance for health, looking at stakeholders outside of the health sector that had a significant impact on the realisation of health and rights, and seeking to expose that power, to challenge that exercise of power, and to support alternatives to that type of decision making. Now, I won't give you a blow-by-blow account of what we have supported in the past 4 years, but I want to touch on a couple of themes that recur across our work. The question of voice, who has voice, which voices are influential, the question of commercial interests and their power within the health sector, and frankly, the question of economic power. And I think about voice, and one of the areas we've chosen to look at is how citizen or community voices are represented in multi-stakeholder partnerships. So we specifically chose to look at the Global Financing Facility, the new World Bank mechanism for reproductive, maternal, child, newborn and adolescent health plus nutrition. It's the new game in town. It's the how development will be done differently by catalysing financing across sectors. If you talk to groups in Rwanda, one of the newer countries eligible for GFF funding, they found out about the GFF stakeholder meeting after it had already started and rushed across town to join the meeting. In Malawi, the civil society groups that are being asked to represent civil society have major conflict of interest with their other civil society colleagues. If you turn to the question of commercial interests, I think Sakiko mentioned that one of the colleagues from Kenya has not been able to be here because of visa reasons, but in talking to colleagues in East Africa, one of the issues that plays out is the very significant influence of private commercial actors on medical equipment procurement in the health service, and the way in which vast levels of resources are being drained from public expenditure in order to support medical equipment procurement for MRI machines and high-end technological devices that aren't necessarily suitable for the health needs of the population, and the health workforce hasn't necessarily been trained to use them. But that return on the investment is guaranteed in the contract, whether those are used to meet health needs or not. And lastly, we can't talk about health without talking about the economy. And I'm struck that we're sitting a few days after the Brazilian election, where activists have been grappling with major cuts to health and education expenditure and the freezing of that expenditure in the Constitution. Is military expenditure frozen? Is defence expenditure frozen? There's a way in which economic choices about what deserves public expenditure and what does not are being played out. So what is the response to that bleak landscape? And I just want to give a sense of what some of the civil society groups that we know of are taking on in order to challenge this governance for health landscape that we'll be discussing in the next couple of days. I'm not sure if everyone knows, but this meeting is happening in the immediate precursor period to the Global Financing Facility events over the next 4 days in Oslo. So over the weekend, civil society groups from across the world are coming together to talk about the Global Financing Facility in advance on Monday of a major development financing conference that will lead into the GFF replenishment event on Tuesday, where it's hoped that the GFF will secure commitments of between $1.3 and $2 billion for health financing in the RMNCEH sector. Some of what we've been funding in Open Society for the last 2 years is support for civil society groups in GFF countries to analyse how decisions are being made, to look at the increasing level of indebtedness that countries are taking on to meet their domestic resource requirements under GFF, and to elevate those lessons into the GFF conversations to try and influence the very operating model of the GFF. On Sunday, there will be a communique from civil society, and I would argue a more critical statement from other civil society groups to say the GFF is not doing the job that it promised to do, and we have to ask questions of how it's operating. On commercial interests, again back to South Africa, where groups like Section 27 framed the constitutional health rights in South Africa as the basis for how the private health sector should be regulated under the Competition Commission's inquiry into the private sector in South Africa. And now those recommendations are being used as the basis to influence the NHI conversation about the operation of the public and private health services in South Africa. Constitutional rights as the basis for how we should regulate and how we should imagine our insurance systems. And then thinking back to the power of the economy, I'm always struck that the health rights activists are not necessarily in the same room as the development finance activists, and the necessity of that cross-stakeholder conversation that Judit referred to. And what we're seeing with groups like Eurodad is that they're taking the very well-worn development finance approach to conditionalities and looking at the health sector. And I know others in this room have looked at this question of what was the impact of international financial institutions' conditionalities on health systems in West Africa before and after the Ebola crisis. We have to merge these conversations about economic reform and public health and human rights. What have we learned in these 4 years? We need to go upstream. We can't just look at the disbursement of contraceptives at clinic level in rural South Africa. We have to look at supply chains. We have to look at who has the power to oversee the financing of those contraceptives. We have to connect global and local. Do the groups working in Kenya around medical equipment connect with the groups in Holland that are looking at Dutch development assistance and the way that trade imperatives influence aid imperatives? And we have to think about who is taking action. One of the most intriguing parts of this work is the way in which engaging in governance has made us move away from almost entirely working with health activists to work with economic think tanks and investigative journalists and social movements and groups working on development finance to connect the dots between these different sectors. But I stand up here, and I've used the word we many times. It's not me, it's not Rosalind McKenna. I'm not doing this work on mapping public-private partnerships or tracing the conditionalities. And I think that does speak to the elephant in the room if Open Society Foundations is speaking to a governance conversation. What is the power of private philanthropy? It's end of year at Open Society right now. The last I's are being dotted and the T's crossed on grants that will go out this year. So while we can have this academic conversation about global governance and who holds power and what is the influence that comes with that power, what is the role of private philanthropy? Why is it that I, because of my institutional affiliation, can have such a significant impact on what gets funded in these fields as opposed to other stakeholders? I don't have the answer to that. And I would hasten to bet that the question of how we address our own power is one of the things that we have really struggled to grapple with in the past 4 years. If there are answers in this room, please find me at the coffee break. This work is invigorating. You see the wins, as small as they are, and Judit gave a really great example of when we actually see progress in some of this work. But you also hear of the losses. You hear of Alex Madaga in Kenya who died because he drove around hospitals in Nairobi for 18 hours looking to get emergency medical treatment. You hear the stories of 143 people that died in South Africa after they were discharged from the Life Isidimeni facility because of the arguments that were made that the care was too costly. If health is meant to be in the hands of the people and accountable to the people, based on that plaque in UCT, what are we each doing to advance that agenda as academics, as civil society actors? And I really do wonder, how would this conversation play out on Sunday with the civil society groups that are working on the global financing facility? Would we even get into the room at the Development Finance Conference on Monday with Gates and the Norwegian government and the Dutch and all of the donors that ultimately will wield the power over what happens to reproductive, maternal, newborn, child, adolescent health? I would hasten to argue they're not necessarily in this room, but unless we speak to those audiences, we will just continue this very esoteric debate. And I welcome all of you to challenge other stakeholders, including private philanthropy like OSF, to take up this mantle and help us to map out some of those alternatives. Thank you.
Thank you. I'll invite all the four panelists to come up now, please, and we'll have a short Q&A session. So, Ulla Petter, David, Judit, can you climb up there? Yeah, fine, very good. Take one of those chairs. Right. Ah. Okay, good. We have a short time for Q&A, and I'm told also we have the possibility of people coming in on Twitter, so I'll have to remember to keep my eyes open over there. So please, questions addressed either specifically to one of our speakers or more generally to whoever in the panel wishes to respond. What am I bid? At the back, there it is, yes. Does that, yes, here we have at the front here. Anna Manuel.
Anna Manuel Byrne from the University of Toronto. I want to ask a question particularly of our last speaker, and here I'm being unabashedly impolite, proudly impolite in Pablo Neruda's terms. And you raised the issue of health and the economy, eyes needing to be turned on philanthropy, and I obviously have been a strong advocate of critiquing philanthrocapitalism and global health. But it strikes me that we need to go much further and look at the source of that philanthropy. So Open Society's Institute, of course, is the fruition of a mass-scale currency manipulation on the part of George Soros some 2 decades ago or more. And the link between this neoliberal phase of global capitalism and the rapidity through which TNCs and global financial interests can manipulate the lives and prospects of literally billions of people on the planet, I think call for far more than academic and civil society alliances and activism, but rather large-scale revolution. Thank you.
I'll take this one. And I'm actually really delighted because I think maybe this goes to David's point about let's have a candid conversation over 2 days. I can't speak for the broad institution of Open Society Foundations or the personal reflections that George Soros would give if he was to be sitting here. But I think you're absolutely right. You know, that actually the very power that we wield is based on the types of, or the power that comes from our finance is derived from the types of economic governance and economic injustice that we would critique. And I think one of the challenges for OSF is really to look at how does an institution that does have that track record in terms of the growth of its economic assets, how does it engage in this conversation with credibility, with legitimacy, with humility? And I could in some ways give you the pith answer of, well, which better institutions to be asking those questions than the ones that have benefited? But I do think there is an imperative on those institutions that have their philanthropic power because of the economic gains that they have made, from which, you know, people have suffered, also have to be part of that conversation. It cannot be something that's externally imposed, but has to be a mantle that's taken up by those institutions. So whether that is, you know, the validity of different pluralist approaches to how we see economic advancement taking place, or whether it really is being some of the actors that are pushing for regulation of the financial sector, we have to be part of that conversation. And we have been part of work around financial transaction taxes, and I think we need to be part of the conversation around how do we seek changes to taxation models that don't allow for the same accumulation of wealth and the avoidance of tax, the accumulation of wealth and the ability of individuals not to be contributors to the tax systems that we were talking about earlier when we talked about something like social insurance. OSF will fund very many different causes, and we can't get away from our institutional history, but it's about stepping up to the plate and actually challenging the power that we have owned.
Thank you.
Hi, Aaron Yarmashuk, also at the University of Toronto. We prefer coming to the Nordic countries and going south currently. My question is for Judit.
Yeah.
I'm just curious about the lack of antibiotic development since 1987. It strikes me that so often it's a focus these days on biomedical solutions. And there's a lot of biomedical solutions, antibiotic development post-World War II to 1987. But maybe it's just not that easy, I have to ask, and maybe it's actually a lot more than simply the financing. So I just want to bring that, especially after 40th anniversary of the Alma-Ata Declaration was just celebrated. The really abundant focus on biomedical versus primary healthcare, public healthcare.
Judith, there you have.
Absolutely. I mean, antimicrobial resistance is a complex issue. It's not, we're not going to solve antimicrobial solution with a biomedical bullet intervention. I just happen to work on the field of innovation of health technologies as access to these health technologies, but I'm very aware of the complexities of AMR and the need for much more sophisticated interventions on primary healthcare to deal with AMR. My point I was trying to make is that the lack of innovation on health technologies for neglected patients has been considered a market failure for the last 50 years. We have known for many years that many patients, especially if you're poor and you live in a poor developing country, or if you're a very small segment of the population, you have a rare disease, just are unintended negative consequences, failures of the current perfectly functioning innovation system. I think antimicrobial resistance and the fact we had not have significant biomedical discoveries since 1987, just 2 new antibiotics, both for tuberculosis over the last 50 years, and one of them with significant public funding by NIH and USAID, shows to me that it's not a market failure. It's a public policy and it's a political failure that is much more significant than just, even if we didn't care about poor people or people with rare diseases, we all should care about infections that are untreatable in hospitals in Europe and in the United States because we are running out of biomedical options. And I think it's an opportunity for a more systemic analysis of what's wrong with the way we finance and incentivize biomedical innovation and the look and the search for alternatives and how we deal with innovation for health technologies. But in any case, I didn't want to say that the solution for antimicrobial resistance is just a biomedical intervention, just the field that I work, but I'm very aware on the needs of more and the importance of primary health care, vaccination, water, prevention of infections, animal food reform. I mean, it's much more complex than that. I was just referring to, this is a case study on the failures of the innovation system.
Thank you very much. The gentleman in the front row.
My name is Walter Ricciardi. I have a medical and academic background because I'm professor of public health at the Catholic University in Rome. But my questions derive from the past 4 years of my experience being president of the Italian NIH and designated by my country to sit in the executive board of the World Health Organization. And of course, I share the inspirational values of all your presentation. But of course, when we meet ourselves in our constituency, we all share this value. But we have to engage, as David said, when we sit in other, a committee. How do you think we have to go beyond? For instance, I just give you a couple of examples. There are 2 years that the ministers of health and ministers of finances meet in Paris, the OECD, in something which is called the fiscal sustainability of health services. I've represented my minister for 2 years in front of ministers of finances. No ministers of health speak up in front of Minister of Finances when they say, and so because I wasn't a minister, I spoke up and I said, your model, your econometric model is not good because it doesn't take into account all the values that we say. And again, when we speak in the executive board of WHO, of course, Dr. Tedros said something very interesting, but then stand up people like, the representative of the United States. We simply say we don't share universal health coverage as a value we attribute very important to the private sector. So how do you see we can go beyond the boundaries of a very good blog, of a very important publication, of our conversation to something which is really affecting the decisions? And do we have to train our people in a different way? Or, of course, we have to teach them to speak up, to be more politically wise, to be more brave. I know this is something that I think we can. How do you see this passage? Because otherwise we will be confronting with very, very experienced and wise people from their point of view, which is the values that we want to fight.
Certainly, Ole Petter and David, I'm sure, would like to respond. Ole Petter first, perhaps? Or David, start. Why don't you start?
The first thing to say is that there are no kind of magic levers or simple buttons that we can press to fix this. The second thing is that it requires different people to act in different ways at different levels of this complex system that we live in. The third thing I would say is that we need to engage outside of our comfort zones, outside of our medical comfort zones or our public health comfort zones, and get our hands dirty. We have to get involved with politics, fundamentally. And I say increasingly to my public health students, who every year come and do a degree in global health, thinking that they'll get some wonderful career opportunity resulting at the end of it all. And I increasingly say to them, you want to make a difference, get into politics. get yourself into parliament. You need to have influence over the leaders of
I was really struck with your talk because it goes, David, because it goes directly to the heart of the question that was raised now, whether we should be reformists or whether we should initiate a revolution and so forth. And this was also part of your question, I think. But yes, there will be a revolution, but it will take a long time, and it goes through education. It simply goes through education. So we have to be a bit patient. I think now we have a time window when we can revolutionize our education. So those that will be the politicians of the future, they will know what we are talking about here and now. It takes time, it requires the involvement of universities, but this is the way to go. And I think the ideal situation, we should not be idealists, I understand, but the ideal situation would be when each and every student that comes out of our universities ask, what is your mission? When he or she goes into a company, goes into politics, or whatever. But it takes time. But I have one other reflection on this, which I think is absolutely, what should I say, mind-boggling, and that is going back to this Northern Future Forum meeting that took place in Oslo just two days ago, with not only decision makers, but the top decision makers. In our report, we say that one important thing is to raise awareness of the problems that we all see for the future when it comes to health and the inequities in health. With due respect to the top political decision makers, and I do respect them in many ways, but this awareness has not reached to the top echelons in politics as yet. I think this is also something we should look at. How come that information is filtered in such a way that top politicians don't relate to the questions that we are discussing here today? As I said, health is very much reduced to something personal responsibility, forgetting, glossing over the political dimensions. I mean, for me, it's absolutely one of the top and major challenges to look at the information flow, or the lack thereof.
Having just thought I would be able to hold time, I'm now faced with many questions and the obligation to stop 5 minutes ago. I'm afraid that I am going to have to stop there because we do have several more sessions. And I know that if I don't hold time, everyone else after me is going to have even more problems. So regrettably, very regrettably, I'll stop there. Do please take the opportunity to use the coffee break to talk to people. I know that Antoine has a couple of practical pieces of information but before I do that, can I just thank the panel and thank you all very much indeed.